Hello, eGP learners. Thank you for joining us on this Saturday morning as we get ready to go live and give you a digital primary care update. How are we doing there, Andy?
Yep, not too bad. Sun's shining over here in my side of sunny Nottingham. How are you?
Yeah, not too bad. It's been a busy few weeks, and apologies to our eGP learners. We know that we missed going live a couple of weeks ago, as we normally would have done, but we did provide some other content for you, and we hope you enjoyed the episodes in the meantime. But both Andy and myself kind of got caught up with the whole vaccination efforts that were going on locally in Nottingham, and with our other hats of primary care clinical directors. And as a result of that, we just had to pause that, and then we've catching back up now, so hopefully back to normal. And here we are, giving you your digital primary care update for today.
Yeah.
How have you
Gandhi,
been, Andy?
how have I been? I've also been in hospital, haven't I, Gandhi? We won't go too much into that, but
Fair enough.
I
Yeah.
can't answer that question without acknowledging the elephant in the room. Although I'm now feeling a lot better and making a full, hopefully full recovery. Yeah, thanks for asking, Gandhi. How are you?
Yeah, keeping well. Busy as ever. As everybody knows, it's been chaos, to be honest, for the past few weeks, with obviously the priority trying to vaccinate as many of our populations as quickly as possible. And obviously, there's a keen deadline many of us are working towards for next week in terms of trying to get through the top 4 cohorts. And I don't know how it's working in your network, but we're really focusing now on trying to tackle particularly the more vulnerable patients from the BME communities and that kind of stuff to try and just encourage uptake. But we're starting to see things flow, hopefully a lot better, and definitely keen to support those kind of efforts that are going on, as well as cracking on with sorting out the networks and practice as well.
Yeah, lots happening. Yeah, and it was interesting to see some of the data emerging from areas about uptake of COVID-19 vaccinations, and certainly there seems to be lower uptake in deprived areas and areas with BMA populations as well. So that sort of describes the sorts of areas you in particular work in, but my area's got some of those characteristics. So yeah, so need to crack on and help those communities access the vaccine.
Absolutely. And I guess people are wondering what we're thinking about covering today. So we've got some interesting stuff coming up for you. We've got a really interesting article that we want to share with many of you, which I know Andy's going to lead into in a second, but also coming up shortly after, as we're talking about telephony in general practice. So as many of us move towards more remote working, and obviously patients as well are having more increased remote contacts with us. One of the big things is telephone bills and that kind of stuff. So we're talking about some news that's come out around that. And then also we've got a little bit of an announcement to make for something that's coming up in April that you would definitely not want to miss, particularly if you're involved with GP education, and just generally some fun stuff as well. So Andy, what are we leading into first though?
So this is related to a story in Pulse that was really interesting that came out on the 2nd of February. But I'm going to ask you a question first, Gandhi. Now, you might have heard this question from other people, maybe patients before, but are you still doing appointments at your surgery? Are you still seeing patients at your surgery, Gandhi?
Absolutely. I don't think we've stopped at any point. In fact, I think we've even gone and done extra days and that kind of stuff, like bank holidays over the time. But why do you ask, Andy?
Well, so people still ask me that, and particularly at certain points throughout the last year, people have asked me that question quite a lot. And there is sometimes it feels, doesn't it, like the media sometimes portrays general practice in a negative light, that maybe, well, the media has it in for general practice, but there's a temptation to go for sort of bad stories, particularly around issues of access. And I think ourselves and a lot of colleagues maybe think that this is the case. And also, I mean, we've talked about the portrayal of general practice in the media, a few times with relation to COVID and vaccines. So anyway, I often ask myself that question: are they overly negative? Is it becoming worse? Is it becoming more negative? And there was a great article in Pulse this week where they did a retrospective analysis of media stories about general practice, looking back over the years 2018, 2019, 2020, and sort of tabulated and graphed the results for us to see if indeed that is the case. So I thought that was an interesting little article for me to bring along to talk about this morning. Do you want to share the screen, Gandhi?
Let's have a look at it, shall we? So if you do want to have a look at this article yourself in a bit more clarity, the link to it is down below in the show notes on our YouTube channel and stuff. But if not, Andy's going through it right now, as you can see.
Yeah, so it's really nice to have a look at on the screen because there's some really nice graphs to show the results. So the methodology, so they reviewed a news database and they did a search for articles that contain GP and or GP and the words access or shut or closed. And that was the standardized approach that they took across each of the years. And then they manually reviewed each article and decided whether the overall tone was positive or negative related to that article. And they've tabulated the graphs here. So initially just negative perception of GPs projected in the article. So there is an increase actually in 2020 from sort of under 25% negativity, which to me, Gandhi, feels low. It felt like things were more negative back then. I don't know how things felt for you.
I think part of the reason why we probably feel that is the headlines are often the attention grabbing part. So I don't know if the studies kind of went into the difference between the headlines versus the content, because often when you read a lot of articles, the headline's the big, it's really negative. And then when you read the content, it's just because the headline was trying to grab your attention and the content is a bit less, but yeah.
Yeah, overall tone is what was graded. So I'm not quite sure. But I think it's another interesting point you make is what was the impact of the story as well, because you might have lots of small stories, because they say good news is small, don't they? You know, it's the small things that are good generally, and you know, bad news is big, you know, or bigger and more impactful. So it might be that we just notice those 25% of stories more. But anyway, increase in negativity in 2020. So we've not been feeling unnecessarily paranoid, it would seem. So does it contain the GP's side of the story? So does it have or seek to provide some balance? You know, is the GP given right to reply and taking it up, which is normally good practice in journalism. I know whenever I've dealt with journalists, they're quite keen to give you your right to reply. And that's a little worse, but generally over 75% there. And is there a sense of blaming the GPs for the negativity? Because you can be negative without attaching blame, and that seems to have doubled essentially from 2018. So I think we can say there has been more negativity in the media. So we've not been imagining it. So yeah, so Gandhi, so that's what it says. Does it feel like that? Does that reflect what you've noticed about media stories over the last year?
Personally, yeah, I'd agree. I feel that the media has taken a definitely more negative tone towards general practice, and feeling that even in times in practice, I can. So we talked a couple of months back about the safety in general practice, and that was spurred by one of our colleagues, unfortunately, having a really negative experience that was driven a lot, I think, by misinformation, you know, about the practice and where they were, and as a result of that, the practice had graffiti done in their premises. Which, you know, is not a pleasant way for things to happen. And I think a lot of that is being stoked by the general negativity and social presence around this stuff.
I think so. A few things that immediately sprung to mind when I was looking at these results was, so I think it feels more worse this year than is portrayed by the graphs. I think that might be because we're all feeling a little bit more under pressure, a bit more sensitive, but I didn't think it was that. I mean, I thought maybe the number of news stories across the year was different, that maybe the proportion of negativity had increased somewhat, but that there were more stories. But that wasn't the case. There were about 150 stories across each year, so you can't blame that. I think you make a good point about the how impactful each story is, and that maybe negative stories are more impactful than positive stories, so they get more of a weighting in the consciousness of society. So what about the degree of negativity and whether actually they were more negative? And I think that's borne out by this sort of blame statistic. But there were some themes coming through that are highlighted within the article, because obviously they're the people who've conducted the study and have a look at the content of these articles. And themes coming through were more blame. They commented on this, in particular for increase in non-COVID deaths, increase in excess cancer deaths and excess deaths from other causes, and potentially related to decreased presentation of heart attacks and strokes, and possibly missed illnesses of all sorts of varieties. So that was one theme. And then there was a big theme, or a lot of activity around this time in the summer in September. And I don't know whether you remember this time, Gandhi, there was a letter from NHS England, shall we say, reminding practices of their obligation to provide face-to-face appointments, which sort of came within the context of Matt Hancock saying at the dispatch box that he could see the future of general practice being, entirely digital. But then I think a few weeks later, this letter came out, and I remember that there was definitely an uptick in negativity from the patients at my practice. I don't know if you remember, there really was that time when we were opening up. I think there was a bit of a relief valve generally on everybody. Some people released complaints and ill feeling, but we got a lot worse friends and family feedback and complaints at that time. So it's just interesting to be reminded of that and to place the increasing complaints within the context of that at the practice. So I think it justifies how we feel a little bit. Gandhi, I was going to ask you a question. So you're very keen on social media, and one of the reasons I thought this might feel worse in 2020 than it did in 2018 is that there's more social media or more social media activity, or social media is perhaps different and more negative than it was a few years ago. What do you think to that dimension?
I think social media definitely has its part to play, because one of the things, like you mentioned, that negative news and news that creates, what should we say, turmoil internally. So whether it's, frustration, aggression, some sort of a negative response, is more likely to be shared than something that's positive or something that's uplifting, that and that kind of, and whether that's because of our human traits or engagement or whatever it is. And therefore, as a result of that, negative stories generally sell better, for lack of better terms. And that's therefore why it spreads better. And unfortunately, the downside of that, sometimes it can be driven by inaccuracies, or, the term fake news is often used, but maybe it's misinformation. And I think it probably goes back to my earlier point, where the headline may be often quite negative, but when you drill down to the facts, actually, it's that tiny element that it's picking up on that in relative terms is actually not really significant. So, for example, you mentioned that letter that we had from NHS England. That letter was specifically designed to target a very small proportion of practices that weren't seeing patients. And even NHS England, in the letter itself, commented on the fact that it was a very small proportion of practices that were doing that. However, the media got a hold of it a few days before practices had even seen the letter. And that's what led to the rampant, news story that went round, pointing negativity, stating that general practice was not seeing patients. And what we know is that it was a really, really small minority of practices that were in that situation. Majority were seeing patients, were having contact. I mean, I've been seeing patients since this time last year, pre-COVID hit. And we just changed the way that we saw patients. That was the difference, and that was the universal difference. But that wasn't recognised by the media. All they said is that GPs are not seeing patients, which has absolutely never, ever been the case.
Yeah, no, absolutely. I think I'm going to make a general comment about journalism, which is completely not my field, and I'm completely unqualified to talk about that topic. But it strikes me that, my memory doesn't go back too long away, really, but it strikes me that journalism used to be better, I think, or maybe I was just younger and more naive, and that what kind of drove journalism and kind of drove the good journalism was selected for, is what I'm saying. Like, good journalism that you would see in the papers and on TV was judged as being good and successful because it was accurate. I think that used to be a priority in journalism, and that's, if you were a journalist and you produce sort of accurate, good quality work, then you did well as a journalist. And it strikes me that now it's actually all about clicks and getting people's attention rather than necessarily the quality of the work. And, there's all sorts of shortcuts or negative ways that you can do that. I'm just wondering if the incentive structure around journalism is to blame. But then again, I'm completely unqualified. So what do I know?
Yeah.
So Gandhi, were you going to say something, Gandhi?
I was just going to say, I kind of agree. I think that there's still definitely some amazing journalism out there, and definitely stuff that focuses on the correct information. But you're right. I think because of the way that journalism has shifted towards the online field, and it's all about clicks and follow throughs and engagement on page and all that, all those metrics that social media and websites use, that clickbait is becoming a bigger part of media, increasingly so. And like I said, negative stuff has a much higher click-through rate than non-negative stuff, unfortunately. And that doesn't help, I don't think.
So let's move forward and try and do something useful with this information.
Sure, let's go for it.
So two questions. So one, why? And then two, what do we do about it? So just thinking about why. So firstly, actually, before we do that, what I would like to see, if I was suggesting further research, I'd like to see a comparative analysis using the same methodology with stories about hospitals, for example, and maybe other similar professions, like maybe dentists, or even just something completely different like lawyers, because it'd be nice to see how general practice compares to those sectors to see whether we should feel justified in being hard done by or not. So that's one thing I'd like to see. But if it were that GP practices are unfairly targeted by the media, then sort of the question is why, leading into what we can do about it. But I don't know, what do you think? Why pick on GPs, Gandhi? If indeed that's happening, which we've not established, but why pick on GPs?
I think there's possibly different answers to that. My personal view would be the fact that because we're so accessible, to be honest, and even though that's what the article seems to be trying to say, we're not. In actual fact, we're the most accessible part of the healthcare system. We are. You can contact your GP, any day that you choose to. You can try and have an appointment instantly. You can speak to a GP, generally speaking, within a really relatively short space of time. You compare that to a hospital specialist who often will be behind various different walls in terms of institutions, telephones, that kind of stuff. It's a lot more challenging to have that direct relationship. And actually, a lot of the times people won't have a direct relationship with a specialist unless they're under their care. So therefore, it's much easier to, in a sense, attack general practice, I feel, because we're so much more accessible compared to every other aspect of the healthcare system. And also, I think all the other parts of the healthcare system like to give their work back to general practice.
Yeah. Let's not go down that rabbit hole just today, but but I agree that that happens an awful lot as well. I think what I would add again is I think we're local, we're accessible, we're also not special. If you know what I mean, we're not specialists. So I think that does something for people's perceptions. I think sort of specialists who are remote, I think it's more difficult for people to criticize them, and people are less inclined to. They'll criticize what's more local and familiar to them. And also I think it's harder to create a good news story around general practice that will get any traction. Person presents early with red flag cancer symptoms and has an early diagnosis of cancer and successful treatment. Like that's a really good news story. But shiny new hospital has multi-million pound new scanner and ward to do exciting new novel treatment. Well, that's going to get in the papers a lot more easily, isn't it? So I think it's just maybe harder to create good news stories around general practice. The final point I would make is I think the government talks a lot about access and how you have access to your GP for whatever you want, whenever you want. They often say things like that. Those are things that I've heard, but they don't necessarily back that up with sufficient funding to make that a reality. They talk a talk, don't necessarily walk a walk with it. So good, right, Gandhi. What can we do about this?
Yeah, well, I think there is definitely an increased need for positivity in general practice and for sharing of the positive work that we do. And I think sometimes that's one of the things that, unfortunately, general practice is also not so great at doing because we're so busy trying to deal with a day job. One amazing positive news story is the vaccination programs in terms of COVID vaccination and how we're engaging with that. And more importantly, how the significant increases that we are seeing in the vaccination rates are, in my personal view, and I'm happy to be told otherwise, in part because general practice has now been able to engage with that because of the logistical ease of the AstraZeneca vaccine compared to the Pfizer vaccine, and also the trust that we have with our patients being able to actually say, well, we can get you in for a vaccination and deliver it effectively and easily. And that's a real positive story that general practice is able to do that. And we weren't able to do that earlier on because of the logistical challenges and things that happen there. But I think it's also about sharing the other positive news stories, how the practices are also engaging with the communities, how they are able to, do the right kind of work that we're meant to be doing. And it's difficult sometimes because you can't give personal case information. That's where we can't say, well, we managed to help this patient really effectively and they had a great experience and stuff, because that's confidential information and things. But new systems, new processes, when something works really well, trying to share that, even if it's just locally, that's often enough for me. Working with our partners and that kind of stuff to share the positive stuff, that can, I think, help to turn the tide. What are your thoughts, Andy?
So I'm thinking, right, fight back is what I'm thinking. So I think historically, GPs and general practice staff probably have been scared of the media and not engaged with them when they've had the opportunity. So I'll say, first of all, I think people should be braver and engage with the media more. I think it's often advisable to do a bit of media training. So I know, Gandhi, you'll have done some media training. I've done a little bit as well, and it really does give the confidence to then go out and engage with the media. And actually, if you're sort of out there on social media, it's not uncommon to get a DM from Sky News or something like that, or somebody wanting you to comment. I know that's probably happened to both of us. So I'd encourage more of us, not for everybody, but more of us to engage more with media in a meaningful way. And I think actually, as we start to work with our primary care networks and practices and other organizations, making sure that kind of media and comms is given the right prominence, and sometimes you can make a connection with a local journalist and feed them some good news stories, because they have to fill those column inches with something, or those airwaves with something. So I just encourage us to, I think we can still complain, but you can only sort of still complain if you're trying to do something about it. So let's take the fight to them.
Yeah, I'd probably put it more about clarifying myth bust more than anything, because often like we talked about, there's often a lot of incorrect or false information pushed around because of people's perception of what's happening. And actually working with the media to try and rectify some of that can be quite useful. I'm going to give a shout out to both the Capital and to the BBC Nottingham team. I've particularly with the COVID stuff, loads of information been trying to share around, trying to make that clearer and more effective for patients in Nottingham in particular. And particularly BBC Nottingham morning team, I've been on a few times, and they're really engaging. They're really keen to try and share the correct information to help the area. It's not just about clickbait and all the other kind of the controversy and all that kind of stuff. It is about trying to generally help, and I think particularly local media is probably better at doing that. National media can do, but national media, they play in a different ball game.
I would say, having had experience of both, I would say they're quite a different kettle of fish, actually.
Yeah.
So local, very keen to inform, and small bits of good positive news. National, they'll often just try and get you to say something controversial. And because that's what the national media seems to be about, really. The final thing I would say is practices and primary care networks and even individual doctors have their own opportunities to communicate directly with their patients. And it might be something as simple as sending your population a text message just saying, yeah, we're still open. This is now how you access services from us. It is different because of COVID, but we are still open. And there's all sorts of other ways through websites, social media, and of course those text messages, which I'm a big fan of, to communicate directly with your patients and maybe get your patient groups back up and running.
Absolutely. And I'm a big fan of using social media to try and engage with our patient practice population. There are loads of different ways you can do that, whether that's Twitter, Facebook, Google My Business, various other social media platforms and things. But taking that on and trying to push forward, it may seem like unnecessary work, but sometimes it can be really fruitful, can be really effective, and you can have really positive outcomes, I've found personally, and from what I've heard from other places as well that have had some really good case histories in terms of why it's helped them and things. And it's one of those things you do unfortunately need to invest a little bit of time in, not too much, but it can work really well for your favor in terms of sharing.
Good. So Gandhi, tell me We've got a big phone bill at the practice. Actually, our phones are top sliced, so it's less of an issue for us. We don't have too much choice in terms of where we get our telephones from, but many practices do, and many practices will have been doing many more phone calls over the past few weeks, and will have been and months, and will have been ringing people on their mobile phones more. So phone bills will be a big issue for some practices. Is there anything we can do about that, Gandhi, or anything been in the media along those lines?
So we're moving on to talk about a different kind of article from the kind of the negative GP stuff, and we're talking about so that there's been a fund created by Innovate UK that's looking to support how we can improve telephony, particularly with a focus in general practice. And they're working with a company called Exxon, who provide telephony resources to practices. I think they cover about 700 GP practices at current, and they're looking at how they can improve this element of, from a couple of different views. So one is obviously making it free for patients to call their practice, which should ideally be happening. If you go back about 10 years or so, there used to be episodes where general practices would use paid numbers that people would have to call, and particularly that was more of an issue when you're calling from a mobile. But as we know, increasingly more and more patients are using mobiles as their first point of contact rather than landlines, and therefore that was seen as that shouldn't happen moving forward. But even now, it's how do you manage the finance of it? Because particularly with us moving towards total triage and increase of amounts of remote working, mobile use has significantly increased, and that costs more. It's just the simple reality, isn't it? It costs more, and it's a hidden cost that I think many places don't recognize, even more so when you're trying to do it remotely. So, I mean, Andy, have you done any remote work during the past year or so, would you say?
Yes. I mean, I use my own mobile and hide the number, and I'm on an unlimited calls package. So for one-off ad hoc issues, I'm kind of comfortable doing that. And I know not all workers can do that. And also, I'm a GP partner, so I'm quite willing to do that. But many members of staff won't be. And I'm actually not quite sure where I am in the small print of my contract, using my personal mobile phone contract for high volumes of work calls. I'm probably in breach of it. So I hope 3 isn't watching this this show. So I've had to work around myself, but I'm not completely comfortable with it, Gandhi.
Yeah, I think that's part of the challenge, isn't it? I think this, for me, it's definitely a bigger issue for remote working, because often when we try and do remote working, it's the IT that's the biggest block. Absolutely, there's that element that you can't see the patient face to face, but hopefully the practice or the service has the mechanisms to help with that. But it's just getting the IT set up. So it's the computer access, the secure N3 access. But then the next one is often the telephony. How do you call a patient? And there are factors to play in with that. So, many practices still use withheld numbers to call patients because of, direct access and making sure that the calls aren't going through to the wrong numbers at the wrong times. Because, the reality is I'm not in my practice all day, every single day. So patient ringing me back on a number that they're expecting to have contact with me, that won't work, and that's not safe as well. But then the other part of that is we know patients often may not pick up a withheld number because they don't recognize it. So then they just don't answer, which is a problem. So can you use localized numbers? Can you use non-general numbers, non-callback numbers, that kind of stuff? That's one possibility. Then there's additional elements. And this is one I didn't appreciate till I read the article. But if you are using your own device, the numbers that you're calling out on will be on your phone bill. And is that a data security issue? Which, I didn't think of that one, to be honest, until I read the article.
Yeah, I hadn't thought about that. That's interesting. Probably is the answer. I'm not sure the Information Commissioner's offices will be knocking down all of our doors next week, but we should always seek to minimise issues in these small, what potentially amounts to a breach. Information not in the hands of people who need to have that information. Oh, interesting.
And then the last one, I guess, is about the recording of the telephone consultations in particular. So video consultation is a bit more challenging to record because the data size is considerably larger, and therefore storage and use of those is a different matter. But telephone calls, many practices do record their calls because there's some clear benefits. So in terms of education, in terms of complaints and managing things, and also just general training and other aspects to it. But then how do you do that remotely? Because often those systems can be quite expensive and significantly make you consider the cost effectiveness of it. But then patient security, there's all those other elements of it that come into play. So yeah, I mean, this is a fund that's being used to try and figure out better ways of doing that for practices in particular. There's unfortunately not a great deal of information about what that will lead into, but the companies are definitely looking into it. And I'm interested to see what this leads to moving forward for general practice, because I think that could lead to, potentially better and more streamlined care for patients if we can get that right, particularly, looking at reducing the needs for withheld numbers and that kind of stuff would be useful. I mean, I when I work remotely, I use a platform called NYE Health, which is really good. It's a VoIP system, so that this is possibly one of the workarounds, creating a voice over internet protocol system. So therefore, there's no storage of numbers, there's no issues in that, and it calls through the internet, but then it calls from a landline number to the patient, which they can't call back to. The only slight annoying thing is it's an Oxford-based number, which obviously for my patients in Nottingham, they sometimes get a bit confused. Why am I getting a call from Oxford? But I offset that sometimes by sending a quick text message saying that you're going to get a call shortly. It's from an Oxford number. Please pick it up. It's your practice.
No, it's good. Sounds like you've found a good solution for yourself. So yeah, so it'd be interesting to see what comes out of this, the grant that they've been given to produce their product or service and address this issue. But yeah, just having that conversation, it's one of those things that in the midst of COVID, I hadn't really thought in too much detail about, but it's the untidiest part of working from home, isn't it? That actually people are using their own devices, and that's not right on a number of levels. So it is something that ought to be addressed, and some sort of tidy system that sits within the laptop or computer that everybody is using simultaneous to their telephone makes an awful lot of sense. So be very interested to see what comes out of this. Definitely.
So Andy, if I remember rightly, you were planning on becoming a trainer a while back, weren't you?
I was. That was at a similar time to when I took on the Primary Care Network clinical director role, and that's sort of taken over a portion of my life, unfortunately. So being a trainer is on hold, but it's something that I'd like to pursue in the future. Notwithstanding, I am still involved in some educational activities at the practice, and it's an area that I might like to learn some more about if there was a good opportunity to do that. So, this is a bit of a clumsy segue into announcing the big announcement for today, which I'll hand over to you for, Gandhi. So what's coming up?
So one of the things is obviously with COVID and all the changes that happened, that some parts of how general practice function has kind of fallen a little bit off the wayside. And one of them that to many may seem like a small part, but is a significant part is obviously we have lots of GP trainers. So GPs that help educate, particularly GP trainees, but also other healthcare professionals in practice and things. And part of that was having the opportunity for trainers to meet, because there's great opportunity for shared learning, for introducing new concepts, and just generally better education, leading to hopefully better education of our trainees and stuff. But that's become a lot more difficult post-COVID, because a lot of trainers prefer the kind of face-to-face engagement and the learning that can be appreciated through that. So myself, Andy, and one of our colleagues, Dr. Tara George, are planning up basically a virtual trainers conference. So many people have been following me on social media over the past couple of weeks, have been seeing me pump out loads of different things, trying to understand what this should look like and what it will be and that kind of thing. And as a result of that, we're officially launching the GP5T conference, and the 5T standing for training trainers to train trainees. Slight bit of a mouthful, but that's why 5T works so much better. So this is our virtual conference that will be on the 24th of April in the morning. It is a Saturday, but we kind of found from most people that was the best time that they wanted this type of learning to be. And we've got some really amazing content coming for you, particularly focus around helping our trainees through the RCAs, the remote consultation assessment, which has now obviously replaced the CSA exam, as well as understanding how to teach consultations to to trainees, particularly shared care management and those kind of engagement parts with the consultations, how to make it flow better. And also looking at how we can support other types of trainees, particularly those from our international medical graduates, as well as trainees with dyslexia. And then just because I'm kind of there, I kind of said I'd do something about tech tips for trainers and how you can hopefully streamline the whole process and things and make training a little bit easier, a little bit less, engaging and stuff, using all the remote stuff that we're now having to do, that kind of thing. So we're using our hopping platform that many of our eGP learners have seen us talk and use in the past, and really, really looking forward to this. Officially launching it today. And feel free to join up. The links down in the show notes and stuff. But by doing so, you get access to the early bird, as usual, one of the things we do for all of our conferences. And in addition to that, you can get access to the recordings if you can't attend, or if you can only attend for part of it and things. So those, as usual, will be available after the event. But if you can make it, it'd be great, because we're going to also be doing things like breakout rooms and that kind of stuff to help, and some awesome networking plans as well. So hopefully this will be a really enjoyable conference. First of many, we plan. And if you do want to sign up, it's hopin.com/events/GP5T, all in lowercase, or like I said, the link's down below in the show notes. And come and join us for our inaugural GP5T conference.
So this should be amazing. And I'd just like to say, £20 early bird ticket, I think it's a real bargain. Looking at the cost of education and this sort of event, albeit face-to-face, pre-COVID, you would be paying an awful lot amount of money. It's just amazing how much more efficient these sorts of platforms can make things. So I'm just really impressed by that. So fantastic. And Gandhi, any other announcements today before we close? I think there are a few more things to mention.
Yeah, so we've got an interesting episode planned for next week. WhatsApp kind of changed its terms and conditions a little bit about a month ago, and that sent loads of people into panic about using WhatsApp. And one of the things we've always maintained is you should not be using WhatsApp for patient level data. If you're doing that, please stop and don't do that. But then the question is, what do you use? So we are going to cover in our next week's episode a couple of different options that you may want to consider when it comes to messaging, whether that's organizational aspects, or can you actually still use WhatsApp? Because I think there's also, we talked about misinformation earlier in this episode. Is there some misinformation about this WhatsApp change that people need to be aware of or not aware of, and what that means and things? So I'm going to cover all that and things next week. So hopefully that will be interesting for you. And we've got hopefully some cool content coming out later on this week as well, which I'm just going to leave it at that, to be honest, because we'll leave some suspense, shall we say.
Excellent. People will have to subscribe and click the bell to get announcements for new content if they want to not miss any of that exciting new content coming up. So please do those things, and comment and interact with us on social media.
And definitely, if you found this episode useful, leave us a like. We really appreciate it if you do. Let us know we're providing great content for you. And as always, eGP learners, we're here to help save you and your patients time by tech enhancing primary care and learning. And we'll catch you in the next episode.